Right now, it's about doing what we need to do to get through today and tomorrow and the next week. Welcome to the Aesthetics Mastery Show, the show designed to help you raise the bar and thrive in your aesthetics career. Of course, more recently, we've been a little bit more focused on this COVID-19 crisis, but today we're heading back into aesthetics. And what are we talking about?
Today we're going to tackle periorbital edema, that tricky complication that happens after tear trough treatment and can be quite upsetting for the client and can feel quite confusing and unnerving for the practitioner. We're going to go through what to do, how to speak to your client, and why it happened in the first place. And then latterly, we're going to discuss Boris Johnson, the UK Prime Minister, who it was announced last night, because we're filming on Tuesday, went into ITU. He'd had corona confirmed for about 10 days, and the progression is quite unnerving for a lot of us. We're asking questions like, have we been lied to? Should he have been liaising with people, a week and a half ago in Parliament? Lots of questions coming out. And actually, of course, we wish him well, but we wanted to kind of debate those out and understand the implications for us.
Okay, so what's first?
Tear troughs, let's go in. So I have had my tear troughs done, I think only twice actually, remarkably, because they last a long time for me. But I actually had tear trough edema. This came on later for me. It was kind of like a few months later. And it was quite upsetting because you do think to yourself, oh God, I want to look better and now I look worse. So why does it happen?
So there are many different reasons it can happen. The first thing to know about this particular area is that you're dealing with the thinnest skin in your body, particularly in your face. So it's 0.2 of a millimeter thick in that area. And then it's so any imperfection is really easy to see. Combined with that, it's also an area where there is often a little bit of increased, so it's probably for the same reasons, to be honest, the fact that the skin is so thin that any buildup in fluid, it becomes very obvious. So you want to look out for people who have a tendency towards getting this problem. So anyone who reports swelling in the morning when they first wake up, and actually all of us have it to a degree. If you look at your face very carefully after lying flat for a few hours, most people will have increase in fluid in their face. But if that shows particularly clearer in their tear trough, then you want to be particularly careful about treating these people and maybe not treat them at all. So patient selection is one of the reasons that people get it. The fact that the area is inherently sensitive to buildup of fluid is another reason that people get it. The second one could be the type of products that people use and the placement or the injection technique that is used. All of these things, there isn't, like in many things in aesthetics, there's no body of evidence to give you a concrete perfect way of doing it that will never cause a problem. There are just tendencies one way or the other where you might have a slightly higher risk doing it one way versus using a different technique. So a good clinician will modify these techniques over time so that you build up a good spread of ways of modifying the treatment to the specific patient in front of you and gradually reduce your risk of getting this problem over time. But it happens to all of us. You will get the side effect at some point.
Does edema tend to show up more for cannula or needle use?
In theory, if you're using a cannula, you're going to be slightly more superficial. Even if you try and get deep, which is usually more painful and more uncomfortable, it's more likely that you're going to spend a lot of the time and a lot of the product will effectively go into the SOOF, so the suborbicularis oculi fat pad, and we're mixing filler with fat. The other way of doing it with a needle is you're placing it deeper and you're putting the little boluses of dermal filler on the periosteum, so literally on the surface of the bone, and then trying to prop up the fat from underneath. Now, of course, all of this is the mental model of what's going on, and we don't 100% know for sure the percentages of filler that get mixed in with a fat pad versus underneath the fat pad with different injectors using different techniques and trying with different intent to place the filler in different places. So a lot of this is built around mental models. My experience is that you get less edema when using a needle and placing it deeper. But I'm sure there are others who feel differently, and we'll say there are other ways of mitigating the risk.
And of course, you're always mixing the risk of that particular side effect with other risks that might cause you to choose to have a cannula as well.
Absolutely. So everything has a trade-off. It's a really good point, and I often say that to people when I'm training, is you should know you can't just say there's a perfect formula. There's always a downside. It doesn't matter what your procedure is. There are benefits and there are downsides of each thing that you do. So if you're going to use a needle, yes, you'll get less bruising, you'll get less edema, but you're also going to have an increased risk of bruising and possibly an increased risk of vascular occlusion. Similarly, if you use a cannula, you might reduce bruising, You may reduce the total number of vascular occlusions, but you might increase the risk of a really big vascular occlusion because cannulas, you tend to put more in one place. So you've got to, you know that you're getting somewhere in terms of your understanding when you can give pros and cons to each procedure rather than saying, oh, this is the right way or this is the right filler. Everything has a good side and a bad side.
But on the topic of filler, though, we do only use two fillers. So which ones are they for tear trough?
So TSL Redensity 2, which has got FDA approval in the States, you'll see it described as the only licensed filler in the UK. That's a great little marketing spin from TSL, from Teoxane, which makes everyone think, oh, they're doing something wrong. But that doesn't really apply in the UK. It's not the same license. But it is a great advantage to know that they have validated their claims through a complex system such as FDA approval. So it's definitely a really positive point for using Teoxane product. I have been using Volbella for years and I know it really well. And I still prefer, I like the longevity you get with it. I haven't experienced the downsides that people sometimes talk about in terms of reactions. In fact, we audited all our patients and found exactly what the data suggested we should get, which is a 0.5% chance, which is standard for dermal fillers for reactions. So I'm confident in that product and I like the longevity, so I use it the most. And they recommend it, the Juvederm recommend it, Allergan recommend it for their for periorbital treatment.
And that, just if anyone's thinking about that study, which showed that there were problems with the Vicross range, you don't have to go into it here, but that was appalling science, wasn't it?
Well, yeah, I mean, it's worth having a look, because I noticed that it's, since we've mentioned it, might as well talk about it. But this all kicked off in probably about maybe 3 or 4 years ago now, and it's a paper you can still find online by Artzi, Artzi, and you can read the paper. And it's worth reading because the headline is very, very gripping. It says, I can't remember exactly, but it's in the abstract. It talks about a difference between, now I might get the figures wrong because I haven't looked at it for a long time, but a 4% reaction versus a 0.05% reaction rate. So they're saying, we discovered that Juvederm, the Juvederm Vicross range produces over 100-fold increase in complications, and that's particularly reactions. But when you delve into it a little bit deeper, you realize that the number that they've generated, it's always important to think of numbers as the output of a system or a process. So the system or the process that they generated those numbers out are so different that you cannot possibly compare the outputs of numbers. And this is essentially the bottom of it, which is they use reported data, which is like the yellow card system that we use in the UK. So as a GP, if I prescribe an antidepressant and someone has a reaction to it, I'm supposed to fill out a yellow card, report it, and then that goes into a pool of data, and then that becomes the post-marketing findings, so the post-launch data that they start to modify risk with. So that's one way of producing a risk ratio. But the other way of producing is that you take a closed cohort of your own patients and you follow them up really, really closely, and you ask them for every side effect and complication they get. Now, obviously, those are ridiculously different methods of getting data on the topic. And it's no surprise that you'd expect to get far fewer reports where you're relying on busy clinicians to fill out reports for every complication they get. The truth is, most of us probably let many of these complications slide because you're very busy doing other things. So now we should report. I think it's a good idea that we all try and report for this reason, but you cannot possibly set up a scientific study and draw conclusions on two entirely different methodologies. But this was shared as an abstract, went viral amongst all the Facebook groups, in our circle, everyone was sharing it, and it put the fear of God in people. And in fact, me too, the first time I saw it, I was like, oh my God, I've been using this stuff for years, I really need to check it. And we audited all our clients over about a year-long period. And we found, thankfully, the same rate of reaction as we'd expect from any dermal filler product, which is reassuring, especially as you've had the treatment yourself. But there are other problems with the paper, like they also weren't clear on their actual outcome measures. So that they sometimes talk about infections and they treat it as infection, but then they seem to include it in their data as a reaction. Sometimes they were talking about reactions and treating with antibiotics. So it was basically very poorly constructed study with a very scary conclusion, which scared a lot of clinicians and basically isn't worth the paper was written on, in my humble opinion.
If a patient texts you or whatever, or calls you and says, right, I've got, let's say they were treated a week ago and they've got this edema now and it's kind of, they say something like, it looks worse than before, what would you do?
So, I mean, the first thing to realize is there are different reasons why you get edema. So they're not always caused by a reaction, for example, which is our worst case scenario, reacting to the product. If it's very soon after the procedure, you might consider that it's post-procedural. Every procedure, every time you put the needle into the skin, you will get a degree of reaction. And that reaction is caused by the procedure, not caused by the product. Doesn't matter what you injected. You may have injected saline and you still have some puffiness because you have a bruise. Remember, bruising causes swelling too. It's normal for your body to react to the presence of blood with inflammation. And so bruising might confuse what you're seeing as well. So the first thing is don't rush into it assuming a diagnosis is always the same diagnosis of edema. Sometimes it's normal inflammation. So in which case, what do? You wait. So it might be appropriate initially to wait, particularly if there's been some bruising on the day. The next consideration would be, is it infection? Now, if it's particularly focused on one side, there was no bruising, and then it seems to be swelling and getting more and more red, you might be dealing with an infection rather than a reaction. As a general rule, you'd expect an infection to be unilateral because it's pretty bad luck to get on both sides. You could get on both sides, but that's one of your differentials as well. You've then also got the one that's most common is that there's just basically a degree of increased water retention on that side because for whatever reason their body doesn't let fluid drain easily from the cheek. It can be because you've got quite a strong orbicularis-ocular retaining ligament, and it could be also because the product is relatively superficial that you're seeing more of it. Bad product is probably one of the most common reasons because for some reason people still don't emphasize the product, and you get taught broadly speaking the technique, one of these training courses where there's 15 people watching and you're just generally trying to do everything in one day, and it doesn't all go in. And even a good clinician with good intent might use basically a bad product, and there's loads of this going on, and then 50% of their clients when they first start will have periorbital edema because the product is designed to hold moisture and add volume, and it's not the right product to use in the tear trough. Okay. So product might be another thing. Finally, reaction is the one to really know about because that one definitely needs treatment rapidly, same as infection, but you need to do something to decrease the amount of inflammation. So it might be appropriate to use steroids in some people. But I would say most of these are to do with a little bit too much fluid, in which case there's a simple protocol you can go through, which I'm sure we're going to talk about.
So they've come to you, it's a week afterwards. It's suddenly, they thought it was, they were fine with it for the first few days, thought it was just normal, but now it seems to be persisting. What would you say to them next? You recommended waiting, but would you say wait for X number of days and then something else?
Yeah, I think it's reasonable not to get involved with anything invasive in the first few days because a lot of it could just be post-procedural swelling. So, and especially if there's a bruise present, you don't want to rush in with high lays because chances are it's going to get better on its own. Bruising, I would wait even up to a month. I've had a number of people who had quite an upsetting amount of edema through one little area that bruised and then basically waited a month and then were really happy with it. So, but that's a long time to wait if you've got puffiness. But the risk you're taking is that you dissolve it, you get rid of it completely. That causes more bruising. They've still got swelling. Then you maybe try and retreat it and they just end up with the same thing happening again. So discretion is the better part of valor, as they say. Like doing nothing is often really appropriate. So the first thing to try often is just to let it settle. Now, I would gauge that depending on how my patient responds, because if someone's freaking out over this and can't carry on with their life, I'm not going to, for want of a better word, quarantine them for a month because of some swelling. It might be better that they don't get the result they were after and you stop if it's deeply upsetting. But for most people, waiting is a good idea. Okay. That's the first thing I do. Now, you can do something sooner still if you feel like this is just a little bit of product. Maybe you've been a little bit generous with the product and a little bit of puffiness, which you can do a little massage. So
is that why you would massage when there's basically too much filler in there?
Yeah, I mean, it sounds, because obviously on the day it often looks normal. It's not like you've just injected a lump of filler and they've got a lump like you could do in other areas of the face. This isn't quite as simple as injecting too much. It means for some reason the filler that is there is holding on to product, or holding on to fluid a bit more. So you can try and move the filler out of that area and take some of the fluid that is holding on with it. So that's a low risk thing to do, which is just to massage the area. So yeah, with gloved hands we use a little bit of arnica gel. You just put it on your fingers and you massage down and out into the cheek, and my thinking is you're underneath, you're pushing it through little gaps in the ligament and out into the cheek, and that will reduce the amount of filler a little bit, and it will take some of the fluid with it. Now, it usually works immediately, but if you haven't taken much product out, it can rebound. And so you can ask your patient to do that at home as well. So that would be the next step. You let them go home and once a day massage the area out. And that seems to help maybe 50% of people.
How many days after the treatment would you do the massage?
I'd be happy to do it if there was no sign of inflammation. One of the simplest things is if you start the massage and it feels more tender than normal, then you've probably got a degree of inflammation left. So you might just want to leave that a bit longer. If you massage an area that's inflamed, it tends to get worse. So it's better not to do anything if there's post-procedural inflammation. So a week is probably about as early as I'd consider doing it. 2 weeks might be better, although quite often people are back a bit sooner than that.
Because they're upset.
Yeah.
Okay. And what happens if, as it did with me, that the swelling comes up months later? Why is that?
Okay, so that is most commonly due to some sort of a reactive process, I think. So it's probably a delayed onset reaction. So I know you've certainly had it once with a viral infection, which happens with all dermal fillers. But it's basically there's inflammation going on in your whole system, and some of those antibodies, some of those inflammatory components settle in the dermal filler and cause a bit of inflammation. It's pretty mild, and it seems to even sometimes last an hour and then stop. But it's not something that if it's consistently swollen, you'd need to do some treatment quite soon. So there's an argument just to leave it and see what happens, and most people it settles on its own. I definitely keep stock of that data so that you're getting an idea how often this happens. But the next step would be to try and reduce the body's response. So now the big thing about this is you don't want to be reducing the body's response if there's an infection that needs fighting. So I would be very cautious about recommending steroids to anyone who's having some inflammation, because you never know if they've got a brewing UTI or a viral infection, and you're just about to make it worse. So I would want to make sure that the patient has zero signs of infection before I started decreasing the response of their immune system.
What happens if massaging doesn't work?
So it's probably appropriate then particularly if the patient is upset and doesn't want to wait, because you could still argue if it's mild, sometimes a bit more waiting might be okay if they are just hoping to get the result without having any more interventions. But I'd say usually after you've tried a couple of weeks of massaging at home, you've massaged in the clinic, it's there every day, perhaps it's even slightly worse, then you're obviously in the realm of needing to reverse it. So hyaluronidase is appropriate. Dissolve the product, get rid of it all, and then you can discuss whether it's worth trying again, maybe using a different technique. If you've used a cannula, you might switch to a needle, or putting less in, you might change your product. This is if the patient's really, really desperate to get the result that they're after.
So let's move on to our corona-based topic, which today is Boris Johnson, the UK Prime Minister, who last night was admitted to ITU. He's had corona he's been diagnosed for 10 days, and he was admitted to hospital on Sunday night, but then last night, Monday, he went that step further into ITU. And most people are being very supportive and saying, come on, Boris, pull through, because it's quite anxiety-making to think that the boss has also succumbed. But some people are saying, well, why weren't we told this is blatantly a cover-up? Or what was he doing in Parliament a week and a half ago? And people are asking questions, how bad is he? So what do you think?
Well, I mean, I'm speculating a little bit about what he's like as a patient, but I would imagine that I have a theory that the more in control you are of your life in general, the less you want to relinquish control to anyone. So I imagine he feels he's probably a bad patient who wants to soldier on. I don't think that it would be responsible of the government even to give the worst case scenario as a potential outcome all the time, because it's quite scary for all of us. So the fact that they said, oh, he's in the best place, they're trying to give a reassuring message, totally understandable. I don't expect them to announce all the ups and downs and his blood results and, that it could be heading in a bad direction. But of course, no one ends up in ITU unless you're seriously sick. So he is, it's not a good situation.
Don't you think that, from my lay perspective, I'm thinking, well, maybe they're just giving him extra care because he's the boss. Maybe they're just kind of being overcautious.
There will be people on his team, I'm sure, who are taking that line. I imagine he will be pushing in the opposite direction and trying to stay in charge and keep doing what he wants to do. So I think there'll be a balancing force. I don't think that the Prime Minister will sit in ITU just as a precaution if he's generally well. There's definitely something going on. And it's, this virus, the older you get, there's certain categories that are high risk.
He's 55, isn't he?
Yeah, he went on for 10 days. This is quite well known that this seems to come in waves. It's a really well described pattern of a fairly mild illness, a temperature, then you feel like you're getting over it, and then suddenly it gets really bad around 10 days in. I haven't read up on all the detail, but it's something to do with a cytokine storm, this big response that the body kicks off, then starts to injure the lungs. I really hope he's not in that bad situation, but if he's on oxygen and he's in ITU, then there's something going on with his lung function, so he probably is. But
he's not on a ventilator yet, is he?
As far as we know right now, he's not on a ventilator.
Okay.
Most people in ITU with COVID would probably be on CPAP, which is continuous positive airway pressure. So they're adding a little bit of help to help you breathe, taking off some of the energy required. And we know he's on oxygen. It's probably a CPAP machine, I would have guessed, but I don't know that for sure.
Okay.
But he's now in a pretty bad category, because we know that he's not the 85% who get it mildly. He's in the 15% who get it more severely. And of course, of the 15% who get it more severely, currently the data is saying roughly 1% of them, higher in the UK. It's actually 4 or 5%, I think, in the UK actually die from it. Mm-hmm. So that's 4 or 5% of the total. So he's now in a category of about a third of the people in his situation actually he might die. So it's pretty high stakes. I really hope that doesn't happen.
Because actually, I mean, this show is not political, but I feel like obviously, many of us didn't vote for him, but in recent weeks, we've all just been like, come on, let's get together. Let's just band together. And I think in some respects, there was a good response to economically to helping businesses with the furloughing, which is for those of you who aren't in the UK, colleagues who are in businesses who cannot function are being given through the government 80% of their wage. But then in other respects, we don't think the government did well, in how quickly they responded to lockdown and all of that as well. But I think generally speaking, we're just like, come on, Boris, get out of this because we need you.
Yeah, well, that's exactly my point of view. I don't think that the thing is with the NHS is there's definitely a perception, and I'm not going to get political here myself. There's a perception that they are not the biggest party for investing in the NHS historically. Let me put it that way. That's quite mild. There'll be people shouting listening to this, but imagine that. But we're now in a situation where we're not going to have another election. We've got what we've got. We've got we're all flawed, but this is the best chance we've got. So my attitude is we need to park political differences, focus on literally the here and now, right in front of us, what needs to be done. Even I do believe there was a delay in reacting. If you see how well Australia are doing, they locked down earlier than us and they're suppressing cases. They're going to have far fewer deaths now. That the UK didn't do that. And there's definitely, once this is done and dusted, we can look back and say who did something wrong, why they did it wrong, was it incompetence, and should we react accordingly? But right now is not the time for that. Right now it's about doing what we need to do to get through today and tomorrow and the next week, and then 3 weeks on, and then once we're on the other side of this curve, then we can start to thrash about who should have done a better job. But right now it's all hands on deck to get through the crisis, I think, and not point scoring from things you wish had been done differently over the last 10 years. It's not the right time.
And do you think that Boris should be relinquishing a bit more control? Because I think he's still trying to basically run the country from his ITU bed.
I don't think he'll be running the country with a CPAP machine on. I think that's slightly when he was in hospital, he was slow. Right. And I imagine a lot of this is put forward. I mean, you just imagine what it would be like for me to try and run the company from a hospital bed, or for you to run the company. Like you might say that you want to be, but you cannot possibly do the same job. Yeah. So he's not doing the same job, but they don't want to say that our prime minister has lost in battle and there's no one in charge. So they won't do that until the very last moment, and then they'll switch to confidently to someone else running the government if that's required. So I imagine a lot of those are statements of reassurance rather than pretending he's got his big desk and everything happening as normal with his CPAP machine on. That's not happening.
Okay. Well, get well soon, Boris. We need you.
If you want to get your own personal protocol for getting through edema from tear trough treatments, you can download a PDF from my website. Have a look in the link in the details below, and that'll be there for you. If you've got any thoughts or opinions on what we've talked about, whether it be the political side or the non-political side, whether it's about tear trough edema or anything else, we'd always love to hear from you. So comment on this and we will get back to you and include it in the next show if we can.
Thanks, guys.